So are there questions from the audience? Yes, Dr. Raj.
So I have two questions, one for Dr. Grothy and one for Dr. Dudek. I'll direct the first one to Dr. Grothy. You had mentioned that in BRAF mutant positive colorectal cancers, the response rates are much better, but the FOLFOXIRI, is that true with the converse in cases of KRAS mutant patients? And how would you treat your KRAS mutants?
So KRAS mutant patients, first of all, or RAS mutant patients, they don't benefit from EGF antibodies. There's no clear benefit in my eyes to use FOLFOXIRI over, let's say, FOLFOX or FOLFIRI, except for patients where you might consider borderline, turning them from borderline resectable into resectable. Because that's the only setting where I would believe, response rate, anatomical response really matters. There are data that was published in Annals of Oncology about a couple of months ago using FOLFOXIRI-Bev in unresectable liver metastasis, and they had a response rate of almost 80% in a liver-limited patient population, liver-limited metastasis patient population. There was a pretty high conversion rate, about 30% to resectability. So in RAS mutant tumors where you really want to force a response for that purpose, I think a triplet combination with or without Bev could be considered.
Just a segue to that question, with liver-only metastases, would you consider FOLFOX plus the yttrium-90 prior to resection versus not, based on the SIRFLUX data?
The SIRFLUX data, yeah. A great question. And, the SIRFLUX data is a little bit puzzling because I think if they had run this trial differently and had not allowed extrahepatic disease, they could have actually seen some positive effect. We haven't done that yet. Do I see a rationale for that? If you really have liver-limited disease and want to force a response, yes, I could see that. The liver-limited disease subgroup analysis, which was, again, an exploratory of the SIRFLUX data, were intriguing. Again, so far we have not done that for various reasons, including also cost. It is more expensive. And, if you then really look at, what would be if you ran a clinical trial, what would be the comparator? Would probably be a triplet combination with a biologic. So we don't have these data. So far, no, I haven't done it. Could I see that it could be useful in individual patients? Yes.
Thank you. Dr. Dudek, I know there's been some controversy about the Wnt pathway in pancreatic cancer. Could you shed some light on that, please?
Well, there are inhibitors of Wnt pathway, and there was quite exciting initial information. And in the randomized study, there was absolutely no difference in outcome. So right now, there is probably a moment of hesitation. What is the role of Wnt pathway inhibitors are going to play in pancreatic cancer?
One last question, I promise, so I won't hog the mic. But I know you've mentioned you spoke a lot about pancreatic cancer. What has your experience been in terms of locally advanced unresectable or metastatic cholangios, and what lines of therapy do you start other than GemCis? So is there any extrapolation from the current pancreatic data to the cholangios?
I do actually, consider cisplatin versus FOLFIRINOX, strategy in this setting, and in my mind, I sort of do that translation in cholangiocarcinoma, which basically we're lacking studies to prove one way or another.
Thank you.
Yeah, also in biliary tract disease, a lot of patients often come in with elevated bilirubin levels, and a lot of oncologists who don't often treat these tend to push them towards hospice or give them 5-FU alone. But similar to what you said, we've had very good experience with FOLFOX-type regimens. Unfortunately, all the second-line trials after GemCis have not been positive, including the recent SWOG trial, which was closed for efficacy.
Dr. Grothy, you mentioned the 4 mutations that we should be evaluating in colorectal cancer patients, the RAS, the BRAF, the MSI, and the HER2. These are all readily available. Are they covered by insurance in these patients?
So, I mean, all of them should be covered because, I mean, the first three actually should be covered because they follow NCCN guidelines. The HER2 story is a little bit more, let's say, shaky in terms of, you know, we have only one study that showed in a single arm and not a randomized comparison that these antibodies work. Now, if you look at the, it's interesting, we talk so much about diagnostic tests, the cost of diagnostic tests. And we have no problems getting ramucirumab in patients, which is $12,000 per month. So somehow, and we, in a HER2 test, probably $50, $100, you know, just actual test costs. So in the end, I mean, this is part of our problem that we're seeing, you know, how to go further and to develop these tests further. And also not just with insurance, but also on a national level, as a chair of the colon cancer task force, we're currently pushing CTEP not just to pay for treatment, but also for the diagnostic evaluation of patients, the screening tests. And you know how difficult it is to make sure that NCI realizes that they have to pay for the biomarkers which we use to identify patients. That's a different bucket. That's so bureaucratic, you know, that they say we pay for any treatment you give, but we're not paying for any diagnostic procedure that identifies these patients that will be enrolled in a clinical trial. So it's, yes, you know, we have problems, you know, sometimes getting the HER2 test charged to patients, insurances. On the other hand, in the scope of things, you know, that's a fraction of which we're doing we have no problem getting a PET scan. You get PET scans, you know, we overutilizing PET scans so much, you know, but we can't get a HER2 test. I mean, yeah. Sorry.
I have a follow-up question to that. You know, in the community, we tend to get mismatch repair protein by immunohistochemistry. Is that an adequate surrogate for MSI high and MSI low?
For clinical practice, yes. So what we do, we have a similar algorithm. We get immunohistochemistry for the proteins, which is readily available, again, very fast. And then when you see MLH1 is, you know, you have a lack of expression of MLH1, you can have a reflex BRAF mutation methylation, promoter methylation test to also figure out is it familial or not. So yes, but for the clinical trials, you talked about all the PD-1, PD-L1 trials, they require MSI high testing, so mismatch repair, PCR-based, 5 PCR reactions, so that's their screening tool. But for clinical practice, I think the protein expression is fine.
Dr. Dudek, I know you don't have a crystal ball, but do you expect the FOLFIRINOX arm to do better in adjuvant than single-agent gemcitabine in pancreatic cancer?
If I would have a crystal ball, then I would say that perhaps I do expect that superiority, replicated in adjuvant setting.
Yeah.
What about the Gemabraxane versus Gem study?
That is interesting. I don't know in that context because the difference was at least numerically smaller.
And what about, what about radiation therapy, the ongoing R2G intergroup study now with the SAC group on board? I mean, eventually it will hopefully give us a result. Do you believe that radiation therapy plays a role in adjuvant therapy? I don't know whether we have radiation oncologists here, you know. It's a religious war at Mayo Clinic. You know, the radiation oncologists are divided. If I don't want radiation therapy, I talk to one guy. If I do want radiation therapy, I talk to another.
I think that it's still going to be only for selected cases. I don't think the novel therapy trials, even biomarker-driven selection, is going to sort it out.
We've been waiting for a breakthrough in treatment of pancreatic cancer for decades now. Since you know the field so well, where do you expect that breakthrough to come from?
You know, it is still a difficult question. So, you know, I also don't want to end the session with again a dismal outlook at pancreatic cancer, especially in the context of excitement with immunotherapy for other form of tumors. I think that even those studies that I presented with new form of cytotoxic agents or anti-inflammatory agents. There are none of those will be a breakthrough. Unfortunately, I think it's going to be a stepwise approach. It is very complex disease, multifactorial. It's not only tumor dependent, but also tumor stroma dependent. And I think that we'll just need to be wiser how to combine those different strategies together.
Can I put pancreas cancer in a positive field? And I have a very personal connection because my mother died of pancreas cancer. So if I had to choose a field again, I would probably do pancreas cancer more than colorectal. It's amazing to see that we're talking about second and sometimes third-line therapy trials now in pancreas cancer. And I think for a long time we made the wrong judgment call. We thought pancreas cancer is a bad disease. Let's give a little bit of gemcitabine. We don't harm patients, and it really didn't work well. The idea that aggressive tumors need aggressive therapies, like BRAF mutant tumors, which I showed you, acute leukemia, so you don't trickle a little bit of chemotherapy on these patients. You give real treatment. So I think what we see with FOLFIRINOX, more than actually Gem/Abraxane probably, is really remarkable in some patients. We have patients who have complete responses lasting a year, which we didn't see with gemcitabine alone. So I think this alone turned our perception of pancreas cancer around. When I see how much drug development trials we have right now, which are smarter than the Gem versus Gem plus X, which we did for more than a decade, I think we have embraced pancreas cancer as a new target for drug development. So I'm a positive optimist, So I actually believe there is going to be a lot coming down the pipe.
Excellent. Thank you very much for that.
Any other questions? All right, if not, we'll break for lunch at this time. I want to remind you that the posters are still available, and I encourage you to visit them in Bay 3 at this point, and also take this opportunity to say hello to our exhibitors in the exhibit hall before they pack up, and we'll reconvene then at 2 o'clock here in this room. 2 o'clock. Thanks.